Good afternoon, everybody. Welcome, and thank you for joining us today for this seminar, Current Approaches and Future Directions in Advancing De-Implementation Research. This event is part of the 2023 Institute for Implementation Science Seminar Series, which features lectures with leading implementation science experts. Registration for upcoming seminars and recording from past events can be found on our website, which is linked in the chat. A few quick announcements before we get started. This seminar is being recorded, and the recording will be posted on our website after the event. All microphones are muted, so please post any questions in the Q&A box, as there will be time for questions after the presentation. CHEST continuing education credits are available for attending today, and details on how to receive credits will be emailed after the event. I'll now turn it over to our Institute for Implementation Science co-director, Dr. Maria Fernandez, to introduce our speaker. Thank you.
Thanks very much, Ricky, and thank you all for joining us today. I'm going to introduce Dr. Wynne Norton. She's a program director in implementation science in the Division of Cancer Control and Population Sciences at the National Cancer Institute. She serves as an NCI scientific contact for several notices of funding opportunities, including dissemination and implementation research in health, the R01, the R21, the R03, and pragmatic trials across the cancer control continuum. She serves as a project scientist for the Implementation Science Centers for Cancer Control, the ISC3 program, and contributes implementation science expertise to the Accelerating Colorectal Cancer Screening and Follow-up through Implementation Science Consortium, and the Improving the Management of Symptoms during and Following Cancer Treatment Consortium, the IMPACT Consortium. She served as faculty for the NCI Training Institute for Dissemination and Implementation in Cancer, or TIDIRC, and is a member of the DCCPS Clinical Trials Coordination Group. She serves on the editorial board for the journal Implementation Science. So Dr. Norton's scientific and programmatic interests include de-implementation of ineffective practices, pragmatic trials and implementation strategies, rapid cycle intervention research in cancer care delivery, and methodological and measurement issues in implementation science. In collaboration with the NCI colleagues in the Healthcare Delivery Research Program, she served as the co-director for a virtual short course on cluster randomized trial designs in cancer care delivery research, and as a co-chair of a virtual workshop on advancing rapid cycle research to improve cancer-related care. Prior to joining NCI in 2015, Dr. Norton was an assistant professor in the School of Public Health at the University of Alabama at Birmingham, and she was a fellow in the inaugural class of the NIMH-funded Implementation Research Institute and a fellow in the OBSSR-funded Mixed Methods Research Training Program. She's a founder and former editor-in-chief of the Implementation Network e-newsletter and website, which provides late-breaking information about implementation science in health to researchers, practitioners, and policymakers worldwide. So we're really pleased that Dr. Norton agreed to give this exciting talk. I know it's a topic that many of us are very interested in. So welcome, Wynne, and I'll turn it over to you.
Thanks, Maria. Can everyone see, Maria and Ricky, can you see the correct slides?
Yes.
Thank you. Good afternoon, everyone, and thank you so much for the opportunity to present today on de-implementation research, and thank you for the kind introduction. Before we get started, I want to note that I have no financial relationships to disclose, and the opinions expressed herein are mine and not official positions of NCI, NIH, or the U.S. federal government. So what I'd like to go through in the next 40 minutes or so before opening it up for questions and answers, although feel free to put that in the chat as we go along, is really walk through some of the need for de-implementation and why are we focused on this, some of the building blocks or core elements of de-implementation that we know so far, including definitions, frameworks, and concepts, some research and some case studies or examples of what we know from the empirical research on de-implementation, some example questions of course, of which there are many that I think are ripe for and prime time for additional research, and then close with some opportunities. So why do we need de-implementation of certain health practices? First, to optimize quality of care. So implementation science has historically focused on underuse of evidence-based practices, and now we're shifting toward overuse of practices for which we don't know that they work, or we know that they don't work, and really trying to optimize quality of care and get toward appropriate use of practices and programs. We, through the literature, have increasingly found and identified practices for which we know they don't work. And this is really exemplified in the medical reversal literature, as well as a lot of overscreening and some of the aspects related there, identifying particular practices that we should de-implement. Of course, such practices, we want to take them out of the system to minimize potential and actual harm to patients, as well as the potential harm, so to speak, of decreasing public trust based on some of these medical reversals and use of ineffective practices. And of course, maximizing use of limited resources. And every couple of years, they do an updated estimate of waste in the U.S. healthcare system with a particular focus on one of those categories of overtreatment of low-value care. 75 to about $100 billion per year is spent that could be perhaps better allocated and used elsewhere, in particular the use of evidence-based practices and programs. And then this recognition that evidence is dynamic, that de-implementation to some extent is going to be inevitable, that we can't always prevent it, and we shouldn't prevent it necessarily in some circumstances, because it's likely that what we know works today is possibly not going to be as effective or cost effective, or something might come along that's more effective, and trying to better understand that and embrace that as applicable. As with implementation science, we see a lot of different terms in de-implementation research. A scoping review a couple of years ago identified 43 unique terms and a variety of definitions. This is one that we offer up, and really, again, emphasizing the study of de-implementation, how to reduce or stop, further clarifying that we're focused on a particular health service or practice, and broadly speaking, I mean clinical practice guidelines, drugs, treatments, medications, procedures, diagnostics, so on and so forth, and really specifying that these are things that are being delivered to individuals, whether that's patients or members of community, by practitioners, whether that's public health or healthcare practitioners, broadly speaking, and it's nested within some type of system, whether that be health departments, community-based organizations, hospitals, etc. I just want to call attention to some of the literature in these other areas that I think are related to and have been in existence for quite some time, and encourage us to consider how these terms and a lot of the research that has focused on this to date can help inform research that we do on de-implementation and the terms that we use. Just touch upon briefly some of the similarities between implementation and de-implementation research. We know the importance of context. We know that partnerships and engagement with end users is really important throughout the research process. Multidisciplinary backgrounds of the research team as well as the partners. Leverage of research methods and study designs, including your quasi-experimental, your experimental, and qualitative, quantitative, and mixed methods designs. Both fields leverage theories, models, and frameworks, some of which are similar, some of which are dissimilar. Recognition of the multi-level, multifaceted aspects of de-implementation and implementation, and identifying determinants and strategies for both. Now, some of the differences here, of which there are several, but just wanted to call attention to a couple, really the starting point. So the starting point for implementation is really trying to get something that we know works into practice or increase the use of it, versus for de-implementation, the starting point is it's already being delivered. And we're trying to either stop or reduce the overuse of it. And I think that has implications for some of the strategies that might be most applicable or most effective. We further kind of call out in some of our work in the field, looking at and really delineating between type of action or behavior between implementation and de-implementation. Again, increasing or starting versus decreasing or stopping in some of the research that indicates or implies that some of the strategies might be different depending on the type of action here. Determinants of de-implementation, of course, some of those are going to overlap with implementation. But essentially, I think we're starting to see more research that affect or emotions, habits, unlearning, medical malpractice, and reimbursement really play a much larger role in de-implementation than implementation. And then trying to build upon conversations in the field around the type of evidence-based practice, the level at which it's being delivered, and the quality of that evidence and how that might play a role, kind of an extension of some of the conversations, again, that have been occurring in implementation research. So what are some of the things that we know about de-implementation? Well, we know that de-implementation leverages theories, frameworks, and models. Some of these are pulling from different scientific disciplines and applied specifically to de-implementation. Some have been developed specifically for de-implementation. You'll see two of the scoping reviews in the past couple of years, one focused specifically on de-implementation for low-value care, 10 theories, models, and frameworks, and another more recent focus on models and frameworks of de-implementation, broadly speaking, found 27. A couple of examples here, Jeremy Grimshaw and colleagues focused on this phased approach, specifically on choosing wisely, and kind of delineating and calling out what the role is of researchers and professional organizations and practitioners and system leaders as one goes through these phases. So the action-oriented of de-implementing something, as well as then leveraging that as an opportunity to advance research in this area. Another framework is one that I was fortunate enough to work with my colleagues, David Chambers and Barry Kramer, a couple of years ago, that was originally published with a focus on oncology or cancer care delivery, but certainly is not meant to be limited to that. And we talked about these 5 different levels and implications for how these different aspects may play a role, again, in kind of conceptualizing de-implementation, as well as identifying some strategies that might be most effective for achieving de-implementation outcomes. And building off of that, calling attention to the strength of evidence of an intervention, practice, or program. And again, the evidence is against the use of it, of something that's already being delivered. And so kind of focusing in on ineffective. So we have really strong evidence that something doesn't work, meaning that it should be stopped. Contradicted, this is really where the medical reversal literature comes in, where we initially thought something in perhaps a smaller sample size or a lower quality study. We originally thought that it worked, and we have more recent higher quality empirical data that suggests that it doesn't. Mixed, so a combination of quality and quantity for and against the use of the intervention that's currently being delivered, and then untested. So things that we provide, things that we do for which we have no evidence whether or not it works. Building on the action aspects from that framework, again, really trying to better understand and specify what action is occurring, what the focus is, how that might play a role in strategies. So removing is stopping something entirely. Replacing is stopping one intervention and starting another. Ideally, that's something similar, so something that's more cost-effective, something that's more effective in that situation. Reducing is reducing the frequency and or intensity of the intervention. So focused oftentimes on screening interventions or screening intervals. And then restricting it is using the intervention practice program with a limited or narrow versus broad scope. So rather than universal screening focused on high risk, rather than being delivered in a variety of different healthcare settings, focused specifically on primary care. Multi-level determinants of de-implementation. These, again, are the different levels that we see in implementation science, including but not limited to these, and how, again, different determinants, barriers and facilitators may play a role in de-implementation, not only in the process, but also then again, identifying what some of the unique aspects are with respect to de-implementation relative to implementation. So I just want to walk through a couple of these examples of the different levels, certainly not all of those levels, but some that I think are relatively unique in these constructs as barriers toward, at these different levels, successful or effective de-implementation efforts. So from the patient perspective or individual perspective, those that are unaware of clinical practice guidelines, and I'm not sure that patients should or would be expected to actually have that knowledge. I'm sure that there are some who print out copies of clinical practice guidelines and bring them to their appointments with their providers, but probably quite the outlier in that situation. Knowledge, kind of misinformation, either from friends, family members, the general public, media, misinformation about why de-implementation is needed, and lack of understanding of that. And affects and beliefs, which again, I think is something that we see far more common and is much more affecting de-implementation relative to implementation. So anxiety over not knowing if you're not doing a test as frequently, distrust or mistrust of medical providers and the broader medical establishment, and focusing in here on fear and risk aversion. And I just wanted to bring in a couple of examples here from a qualitative study that focused on better understanding why patients were continuing long-term antidepressants when it was indicated or contraindicated and should be discontinued by empirical evidence. And we've seen a lot of focus on this in recent years. And so fear and risk aversion, this was one patient who was really fearful of not necessarily the side effects, but going back to that place that she was in prior to going on the medications. And so not entirely believing that it would, that she wouldn't go back to that space. And that was one of the barriers. There's another quote here that's focused a bit more on risk aversion and the potential risk of not taking these medications, not only from a personal perspective of experiencing the symptoms, but also from an interpersonal perspective in the relationship with this individual, with his partner, and how that might be affected if they went off the medications. Switching to provider level barriers, medical malpractice, again, which is something that is far more common, most likely in de-implementation issues and overuse. Habits and unlearning. So to the extent that providers are delivering something and have been delivering something or using something for 5, 10, 15, 40 years in the past, how to break that habit. And unlearning, so how to stop doing something, and particularly with respect to replacement and the types of unlearning behavior that may be needed depending on the type of intervention. Affect, cognitive dissonance, and professional norms, again, things that I think we're going to see more frequently in the de-implementation literature relative to implementation. So provider level barriers wanted to, again, pull in a qualitative study that looks and has some support for affect dissonance and professional norms. And this was from a study that looked at 2 large quality improvement initiatives focused on inpatient pediatric care. One focused on bronchitis, the other focused on community-acquired pneumonia. And really, one of the providers, and you can think of this as a really high stakes situation, right? So you have children who might be hospitalized or even, transferred to the PICU, and providers interacting with family members or caregivers who may be present. And so really the fear here is quite strong, and I think rightly so. But again, this type of fear, this type of affective behavior with implications for strategies. Another here is the cognitive dissonance that providers may feel. So to the extent that they've been doing this for a very long time, and now they're being asked not to do it, what the cognitive dissonance is there in that situation, and how do they reduce it? And kind of coming to terms and acknowledging that and trying to manage it without it leading to resistance to de-implementation. And then professional norms, and kind of reflecting here that providers and the field of medicine, broadly speaking, are focused on fixing things, and oftentimes that means providing things. And so really trying to focus in on those professional norms, as it is historically focused on trying to do more rather than trying to do less. Setting level barriers, so certainly kind of organizational context at the setting level. Loss of revenue, so if there are few, if any, revenue generating alternatives. Defensive organizational culture, which is certainly something that we see play out in implementation science. If it's hierarchical or there's poor communication of why de-implementation needs to occur, there's likely resistance there. And then structure meaning components of the organization, characteristics of the organization, whether it be a hospital, community-based organization, primary care, different types of settings, again, where this ineffective intervention is being delivered, some of those aspects that may serve as barriers or are related to de-implementation. And so one example here, and I won't go through certainly this entire table, but I encourage you, if you're interested, to look at the reference here. But just highlighting some of the factors here that are independent predictors of overuse based on an overuse index that they created. And you can see here a cross-sectional study look with 676 US healthcare systems, that certain factors, the structural factors, were associated with greater overuse. So those that were overusing healthcare had more beds, had fewer primary care physicians, more physician practice groups, more likely to be investor-owned, and were less likely to include a major teaching hospital. So there's probably a lot to be uncovered within this with respect to structure, but I think acknowledging and recognizing that some of these elements that may be more challenging to change should be acknowledged nonetheless. And finally, societal level barriers. So policy, whether that's kind of your small p or large p type of policy, reimbursement, certainly driving and facilitating de-implementation as a determinant, and societal norms here. So norms that are really focused in on more care is better care and how that might be a barrier toward de-implementation. And this study here, again, I won't go into the details. If you're interested in reading more, certainly the reference is at the bottom there. But I think it's a nice illustration of the interaction here between policy and reimbursement. Policy in this situation, referring to the initiation or the release of Choosing Wisely recommendations in the US and those in Canada. And this is a really interesting study. It focused on two low value types of interventions or programs, screening tests, including vitamin D here. Really large systems in using interrupted time series design to better understand how the implementation of these particular, you might say, de-implementation strategies, to what extent they led to a decrease in use of vitamin D. And so in 2010, you see between Canada, US commercial and US veterans, you see around 2.5 of the tests per 100 qualifying visits. Started around the same baseline, so to speak, of 2.5-ish, 2.6-ish. And you see what's known in interrupted time series design between 2010 and 2011, a steep drop there known as the anticipatory drop of recognition that likely they had a heads up, so to speak, that the formulary was going to change and the policy was going to be implemented, eliminating reimbursement of vitamin D screening. And so you see a significant drop there starting in 2010 and through 2011. And you see that slightly increase over time, but not that much. In contrast, certainly the US wasn't subject to the delisting of the vitamin A. You see the initiation of the Choosing Wisely campaign, the US recommendations shortly after 2013. And you see in the orange here for commercial, quite a decline there. The slope isn't nearly as steep as from the policy the reimbursement, but you do see a bit of a decline. You see a little bit of an incline for US veterans, integrated delivery system, but certainly not as much. And so really calling attention to the greater reduction associated with payment policy change relative to initiation or release of policy with respect to recommendations or guidelines, and recommendations for better understanding how these paired together and the timing of how they're paired, whether sequentially or concurrently, might affect and try to maximize reduction in use of low-value screening tests. De-implementation strategies, certainly reflecting those types of approaches or things or methods that we do collectively to drive or support de-implementation, and really trying again to build the state of the science around what strategies are effective. What do we know works? What don't we know works? What is still something that we need to better understand? And I think it's an opportunity to leverage what we know from implementation strategies and really move the needle in terms of better understanding what strategies might be needed over time consistently, what strategies might be time varying, and as well as what strategies might be needed to maintain de-implementation or de-adoption after that has been successfully achieved. There's also consideration of how the strategies might be different based on these characteristics, as well as interaction between these levels, whether it's interventions, types of actions, multi-level barriers or determinants, and the context or setting. So, for example, some of the de-implementation strategies here that might be effective, that are different from the case studies that I just showed, is patient education focused on inaccurate beliefs, if that's the case, and some of the strategies that might work there. Legislative tort reform for fear of medical malpractice, certainly that is quite difficult to implement, but something that is increasingly focused, and empirical research suggests that it does reduce fear of medical malpractice and actual incidence of it. Identifying alternative sources of revenue for organizations or settings in which low-value care is being delivered, and then campaigns and media coverage to try to address this issue or the societal norm that more care is better care. There's a recent scoping review that was done looking at strategies for de-implementation of low-value care and mapping it on and comparing it to the implementation strategies or the ERIC strategies. And they found really some of the strategies overlapped, some of them didn't, implications that there are some strategies that are being underused or not even applicable to de-implementation. Now, again, I think this is a function of what's in the literature, and perhaps there are things specific to low-value care for strategies. So really an opportunity to not only build on what we know, but try and expand and think creatively about some strategies that may not at all be in the ERIC compilation. This is another recent study looking at strategies that have been tested in randomized controlled trials, so your cluster trial, stepped wedge, individual randomized. They found 227, and you can see here the number of randomized controlled trials in each intervention category that was tested. Certainly these, a lot of these were multifaceted and combined, which is interesting and promising that we do have this information. Limitations that 66% were conducted in a primary care setting and 72% focused on drugs or medications only. So really an opportunity to build on this information from the literature, but also expand it. To what extent are de-implementation strategies similar or different from primary care settings to hospitals or to public health organizations, or focused on interventions that aren't medications and aren't drug treatment? So a real opportunity here. De-implementation outcomes. If you map this onto the different types of action, either removed, replaced, reduced, or restricted, and different metrics for measuring those. If you use administrative claims data, self-report, qualitative data, a combination of those, trying to better understand what are the data sources that could be leveraged that are already being collected to assess whether or not de-implementation occurred, as well as a function, again, of these types of actions. Time to de-implementation, which is something that we're thinking about increasingly in implementation research. So how quickly can one achieve de-implementation? Again, a function of what the target outcomes are and how they're being measured. And I think one unique aspect here is that how quickly or the pace at which de-implementation occurs. I think there might be an argument that sometimes it should occur purposely slowly. Sometimes it should occur purposely quickly. And sometimes you might want it from slow to quick or vice versa, depending on, again, what type of behavior is being or action is being done, the type of intervention, that's being delivered, and some other factors. So better understanding how quickly that should or could occur. Cost to de-implement, as well as we're thinking in implementation strategies too. So how much does it cost? What are some of the most cost-effective strategies relative to others? And can we try to better understand this? So what do we need to learn about de-implementation if you consider that kind of some of the building blocks or the current state of the science? I just wanted to offer up a few of certainly many questions that are in existence, pulled from the literature here, and welcome and would encourage anyone and everyone certainly who are interested in this field to dive right in. So 3 questions here. The first, at least that is something that I personally think is interesting, and there's some obviously based on these articles, discussion in the literature of, can we optimize implementation by starting with de-implementation? And so you see here some evidence that that might be effective, rather than starting with implementing something and then either de-implementing or not addressing de-implementation at all. So the sequence here being important, starting with de-implementation, because I think one of the main barriers toward implementation is time, money, and resources. And so if you can de-implement something that we know doesn't work or is ineffective or is something that shouldn't be done, you create that time and space to implement something that is evidence-based. And what that can do to the culture of those and the settings in which that is being done in terms of trying to create organizational support for implementing new practices. So we see that in the educational literature around school-based speech sound therapy. We see it, which is one of my favorite titles of any article I've ever read, Getting Rid of Stupid Stuff, which was really more of a practice improvement where the nurses and physicians collectively identified different functions in the EHR that were redundant, that were ineffective, things that really took a lot of time for which there was no need for it to occur any further. And one of the quotes here is, stupid is in the eye of the beholder. And starting with that, they identified these different practices or changes that needed to occur in the EHR, and recognizing that there was likely at some point in time a good reason for what was done. And so kind of setting the stage for it's okay that we are finding things that we should stop doing. And then again, what that does for cultivating organizational support for implementing new practices that we know work. And finally, this article by Mina Johansson recently in BMJ that introduced the idea of TNT, time needed to treat. And again, to the extent that implementing new practice guidelines requires a lot of time, or at least some time, to the extent that one can match the time needed to treat with the de-implementation of something that's ineffective, again, kind of creating that time and space to facilitate implementation if you start with de-implementation. Another question, I think, which is quite timely in public domain is, how can we enhance patient and provider trust while striving to de-implement ineffective practices? So an opportunity to engage communities and consumers in supporting high quality care and framing it as high quality care or appropriate care, rather than we're de-implementing something and we're taking something away from you. I think health communication interventions or strategies might be most or greatly applicable here for de-implementation. Of course, there are some in existence already, but certainly more research that could be done to facilitate this. And then the third question here is, how do we mitigate unintended negative consequences that result from effective de-implementation? And these are just some of the issues that could come up from effective de-implementation efforts, whatever that outcome, primary outcome might be. I think these could be some secondary outcomes of negative consequences. There are some methodological challenges here in terms of measurement and study design. Oftentimes, once one has achieved de-implementation, for example, in a trial, one doesn't measure either sustained de-implementation or the potential longer-term unintended negative consequences. And so how does one identify these, measure these, and then consider what implications this has for what de-implementation strategies are used at one point in time during that process, and what strategies might be needed not only to maintain de-implementation and those outcomes, but also to recognize that this may come up after de-implementation, and these types of strategies might be needed to mitigate these unintended negative consequences. Walk through some opportunities, initiatives, and resources. First, funding for research in this area, of course. The NCI, as well as many other institutes, centers, and offices, have 3 different funding opportunities focused on dissemination and implementation research in health, your R01, your R21, and your R03. And new in the past cycle or 2, we've had an explicit call for studies on reducing or stopping, de-implementing the use of clinical and community practices that are ineffective, unproven, low value, or harmful. Really trying to encourage the field to submit more applications so we can better understand de-implementation and move the needle in the evidence base around de-implementation. At NCI, we are fortunate, and some other institutes and centers, that we have PIs in their respective institutions and research teams who have graciously agreed to share copies of their successfully funded grant applications. This is just one, thanks to Ted Skolaris and his colleagues, that's focused on de-implementation and specifically around chemical castration in prostate cancer. And the 3 aims here, again, trying to understand barriers to de-implementation, identify what strategies might work best, and then piloting those strategies in preparation for a larger trial. These are some of the more prominent networks, initiatives, and collection of articles and journals. A U.S. Deprescribing Research Network, which has a lot of helpful resources, the Deprescribing and deprescribing.org in Canada, again, both focused on medications specifically. The Less is More from JAMA Internal Medicine and Too Much Medicine series in BMJ are a collection of articles, BMJ going back to the early 2000s, focused on de-implementation or de-adoption or overuse, overscreening, overdiagnosis, overtreatment. I'd encourage you to check out some of those really interesting articles. And the Choosing Wisely campaign here that I alluded to earlier with the Interrupted Time series design, which was initially started in the US and then grew across the world, international campaign, and some of the work that's being done. Again, really interesting series or collection of campaigns as well as empirical research, trying to better understand how to leverage choosing wisely to drive de-implementation. I wanted to call attention to this particular international conference focused on overdiagnosis, Winding Back the Harms of Too Much Medicine. It is supported in part by BMJ and links to that series of Too Much Medicine. This past summer, it was in Copenhagen. They are increasingly focused on de-implementation strategies or how to reduce overuse, overdiagnosis, overtreatment. Save the date in September 2025. For those that are interested, I'm happy to share information about this. I've been lucky enough to serve on the Scientific Planning Committee for a couple of years, and really think that it would be a nice opportunity for more research and more discussion on de-implementation for this particular conference. And for those that are attending the Conference on the Science of Dissemination and Implementation in Health next week in Arlington, Virginia, I pulled a couple of examples here of different sessions that are focused on de-implementation. This is certainly not comprehensive, but just wanted to highlight some of these if you're interested in attending, if you're going to the conference. And some textbooks, each of which have chapters focused specifically on de-implementation. And with that, I will stop, pause for questions, comments. Thank you.
Great. Thank you so much, Dr. Norton. That was an excellent talk. We do have some questions in the Q&A, and I'll just take them in order. The first one is, can you speak about any specific components that you think make a good de-implementation framework? For example, are there theorized determinants, mechanisms, et cetera, that are particularly needed in de-implementation? TMFs that might not be present in traditional implementation theories, models, and frameworks.
An excellent question. It's a very complicated question, but I appreciate it nonetheless. I don't know. I think that would probably be with respect to any theory, model, or framework, in terms of providing practical guidance, pulling from the literature, being generalizable where it should be. Again, I'm not sure that there's anything unique to de-implementation aside from the components, but not necessarily how that theory, model, or framework is developed. And there's a really nice article by Greg Ahrens and colleagues focused on the practicality and the utility of theories, models, and frameworks and implementation, and kind of how those go hand in hand in guiding what practice efforts might or should occur. And I think a lot of those elements are applicable to de-implementation theories, models, and frameworks.
Right. The next one is, can we do de-implementation and implementation research at the same time?
Yeah, great question. Excuse me. I think so. It can either be sequential or concurrent. So to the extent that you at the same time are replacing something, that you can try to de-implement one thing and implement another thing. I think that's a nice opportunity. There might be additional kind of contexts in which you can study de-implementation and implementation research at the same time. I'm really trying to, I think, better understand there's some of the research and methodological complexities of doing that, and ways in which you might want to set up your study design and collection of data to facilitate de-implementation and implementation research at the same time if you're doing it concurrently, with an eye toward not overburdening participants in terms of the data that you might be collecting.
I'm gonna read you the next two questions, one right after the other, because I think they're highly related. One is, would risk assessment tools be useful in establishing guidelines that would restrict particular care strategies for those at higher risk? And then the other one is, to what degree has the concept or variable of risk-benefit ratio been incorporated into de-implementation theories, models, and frameworks? It seems like it would be a key influencer of behavior. De-implementation of low risk, for example, no harm, low cost interventions, would likely be less successful than the implementation of high risk, significant harm, or potential or high cost interventions. So yeah, just a little bit on your thoughts about risk assessment tools or the risk benefit ratio assessment and how that may influence.
Yeah, great questions. Thank you. So trying to answer these, again, to the extent that they overlap here. I think what might be important here is classification of the type of intervention. And by that, I mean kind of what interventions might be easier to de-implement versus other interventions. And so a function of those intervention characteristics and the strength of the evidence. Now, low value care is not no value care. So I think trying to better understand to whom the de-implementation should occur. And then some of the aspects in the framework that we used, at least focusing on how do you prioritize those? So digging into kind of the harms, the potential actual harms to patients, and taking those into consideration. I think folding those into theories, models, and frameworks. I think they can be included in some of the constructs already. It's just a function of if they are facilitators or barriers. So I think it speaks to kind of the risk-benefit ratio as a function of what the intervention characteristics are and the potential for harm, and whether it's higher risk or lower risk, and the sequence in which you might want to consider de-implementation.
Great, thank you. What about, so here's another question. What about cases where de-implementation is occurring because of a loss of funding in community settings? Is there an effective approach for preparing the community for cessation of a beneficial intervention?
Yeah, great question. Thank you. A nice example of this is work led by Ginger McKay at Washington University in St. Louis, who looked at some of the factors at the organizational level for why community-based organizations no longer offered particular HIV prevention interventions. And one of the things that was quite prominent here is the loss of funding and how that influenced or dictated what intervention was continued and what was discontinued. I don't know that there is yet to be a strategy specifically, but I think it would overlap quite nicely with sustainment and some of the sustainability elements that Doug Luke and colleagues have really championed, focusing on how can one prepare for sustaining de-implementation in terms of trying to identify what those additional revenue sources might be. And to what extent you might need to do that first versus after de-implementation.
There's another question, it looks like, of a situation where a provider may be de-implementing overuse. It's from an anonymous person. It says that an elderly friend of mine, 85, was told by his gastroenterologist that he no longer needed a colonoscopy. He had had regular screenings because the risk of harm was greater than the benefit from the screening. He was quite upset. Comments?
Yes. So disclaimer that the opinions expressed here in are mine and not representative of NCI, NIH, or the U.S. federal government. And certainly I am not a practitioner, so I can't really speak to that. But I appreciate it is a very real and very common issue that patients face. I think, and that kind of reflects the issues around kind of the patient affect and fear and being upset and being concerned. And I think, you know, I am sorry that your friend experienced this. I think it speaks to consistency with clinical practice guidelines, as well as an opportunity to improve patient-provider communication. And some of the work that I think still needs to be done to make sure that during those conversations, if it's pretty clear that some intervention should not be used, explaining that to patients so they're on board. If it's a situation where in this situation where the risk of harm was greater than the risk of benefit, certainly that might be an opportunity that warrants some type of shared decision-making. Again, depending on that risk ratio, risk to benefit ratio, for some of these where we don't have evidence or we're unclear around what the evidence suggests, I think that's an opportunity for shared decision-making.
When just because we do have a little bit of time, so just pushing a little bit more on this or expanding it perhaps. I'm wondering if you have any thoughts or know about planning for implementation strategies that can deal with this kind of situation, right? Because we know that sometimes it's providers, sometimes it's patients that are attached to a particular practice in this case, which may no longer be beneficial for them. And I can imagine, as in this scenario, that could take some training, particularly for the providers, to be able to kind of handle something like this. And I'm wondering, to what extent do we see that in de-implementation strategies, sort of attempts to address this this challenge that they may encounter with their patients as they're, you know, appropriately trying to de-implement a practice?
Great question. Yeah, I think it plays into a couple of things. Professional norms, anticipation and agreement of those things that should be de-implemented, behavioral skills building, so anticipation of questions from patients and how one might deal with that. yeah, it's challenging, and I think they're an opportunity again for more research in this area.
There's another question. What are your thoughts on de-implementation of medications versus other low-value care? Are these strategies similar or different?
Another great question. Thank you. I think the jury's still out, and I think that's really an area or one area where we would benefit from more research to better understand, kind of tease apart what are some of the intervention characteristics, practices, programs, drugs, treatments, guidelines, and how those different types of interventions may need different strategies or may present different barriers relative to low value care, again, which isn't no care or no value care to certain patient populations. So I don't know that we have an answer. I think it's another aspect to better understand through research and try and identify where things might be, the strategies might be similar or where they might be different based on intervention characteristics, patient determinants, provider determinants, so on and so forth.
Thank you. Let's see, another question. How do you think your experience and examples of de-implementation can inform general evaluation of public good initiatives rolled out by local and global NGOs? Thinking specifically about large, well-known nonprofits who have taken on global healthcare deficiencies and ostensibly being serious about measurement evaluation, but there might be other considerations for them to de-implement.
I'm trying to take all of that question in.
Yeah, the way I'm interpreting it is, you know, in addition, and the person who asked it, we can, I think Ricky, we can allow you to talk if I'm getting this wrong. So just raise your hand and we could unmute you. But the way I'm understanding this is that de-implementation, you know, obviously it's an important implementation science sort of issue, and there's important science around it and advancing it. And so, but what about like in general, you know, public health, or in this case, local and global health efforts that are sponsored by NGOs? How does it play into how we interpret and what we do with evaluation results? So when evaluation results are telling us that something that has been implemented is not working, like is this something that we should be thinking about from a de-implementation perspective? That's sort of the way I was interpreting that question, and if I got it wrong, please let me know.
Thank you, Maria.
Do you have any, do you think that some of the things that you've been talking about apply, like even when it's not a practice necessarily that has been in practice for a long time that now needs to be de-implemented, but maybe a large scale effort that people have put a lot into, but they realize, oh, well, you know, it didn't really work.
Yeah.
Is that something that should be also considered?
Yeah, I think so. Some of the cognitive dissonance around that, and you know, professional norms, to the extent that that is present as well. And I think really embracing this idea, which is uncomfortable, but it is reality, that evidence is dynamic, and that we're going to need to de-implement things or replace things regardless of how good of a job we do in implementing something. So I think embracing that idea, which is similar to the learning healthcare system, of we're always learning, we're always changing, and how best to set ourselves up for embracing that without having negative reaction down the road, again, where, you know, our team has put so much time and effort into this, and now we have to encourage folks to stop doing it because we have better evidence. So I think the communication around that, the framing around that is going to be really important, and really important to engage our community-based organizations and our partners in better understanding that and how to frame it.
Yeah, I really like this concept, because it's sort of you know, thinking proactively, like we're encouraging people to always think about sustainment, right? And but also by the same token, we have to think about de-implementation if in fact it doesn't work. So I think that it's an interesting thing to think about. I don't see, I guess one more question, is there a direct relationship between de-implementation science and quality improvement of healthcare interventions?
Yeah, another great question. I think, again, it's how you conceptualize and define quality improvement, of which there is variability. I think, quality improvement and, for example, Plan, Do, Study, Act, PDSA cycles can certainly be applied to and have been applied to de-implementing a practice. Now, certainly, again, there are different factors associated there. Maybe the PDSA type of cycle works regardless of whether you're implementing something or de-implementing something. Again, I think the jury's still out on that. But I would say that quality improvement, if you're looking at quality improvement research, would be a nice opportunity to conduct de-implementation research.
Great. Thank you so much, Dr. Norton. I think that's all the time we have for questions and answers. I'll just turn it over to Ricky to let you know about where you can find the recorded talk and the slides. Thank you once again, Dr. Norton.
Thank you for having me.
Yes, thank you so much, Dr. Norton. Thank you, everybody. The link to where the recording will be posted is in the chat, as well as the link to register for our last seminar in this year's series. So please check those out, and you can email me if you have any questions. Thank you all so much for joining us today.